Hello and welcome to the April 2023 NATS Chat. I'm Kari Ragan, moderator of NATS Chats, which are sponsored by Inside View Press, for which we are very grateful. I am thrilled today to be joined by my esteemed colleagues and friends for our part 2 of the conversation about the singing voice specialist, controversies, and collaboration. So thank you, Peggy, Marci, and Leda, for joining me again.
Happy to be here.
Thank you.
We all did, we rewatched part 1, and I have to say, beyond the trauma of having to watch and listen to ourselves, I was really thrilled by the conversation that we had. We really put a lot of fantastic information on recording so that people that are interested in this aspect of our profession can see from where we come. So just as a reminder, a few of the things we discussed, different paths within the team approach or different models to do this work. There isn't one model, there are many opportunities. Peggy gave a fantastic history of the development of the singing voice specialist. We discussed the term SBS and potential changes, and we're going to talk about that a little bit more now. We discussed the requirements, the extensive requirements to become an SBS and what we felt would be the training background. We mentioned conferences of a multidisciplinary nature, and we discussed habilitation versus rehabilitation, among other little tidbits. So all of that is recorded for people and uploaded to the YouTube OfficialNATS channel. So I encourage everyone to watch that. So we're going to dive deeper today. We're going to get into the gray area and just see where the conversation takes us. I want to begin with this conversation. I put forth something around the designation between a singing teacher, singing voice specialist, and a speech language pathologist, singing voice specialist. And Marci and Leda actually have both been using for their profession, clinical singing voice specialist, which I think is wonderful and much cleaner than my SLP-SVS. And so, Marci, do you want to just talk for a moment about that, and then we'll dive deeper?
Sure. I actually, this term entered into my head back in 2013, Kari, when we were all in I think it was Utah for the very, very first, and it was sort of very clear that there were two segments of professionals that are needed and that to serve this population, but the largest thing that distinguishes them is that one is in a clinical arena, and the other one is sometimes within the clinical arena, but often outside of a clinical arena. And so to me, a clinical singing voice specialist differentiates me as a speech pathologist clinician who is working to restore function. We've talked about sort of the distinctions between that, but I'm doing it in a clinical arena
and
within my body.
And you're licensed to do so.
Right.
Yeah. Right. So I love that. So, oh, Peggy, I can see you.
A quick question about, just for me, for clarification. So, Marci, for you, you are a licensed speech language pathologist, and when you practice singing voice specialization in the clinic, you are a clinical singing voice specialist. How about someone like myself who's not a licensed speech language pathologist, but perhaps an experienced singing voice specialist practicing within a clinic?
Right, so that's where I think I think a singing voice specialist is the term that I think is used, Kari. That's the term that you use. How do we distinguish the pedagogy kind of arena from the clinical arena? I don't know. Is it a singing voice specialist pedagogy? In my clinic, we refer to the Kari Ragan and Peggy Baroody professionals, which are 𝗓cie𝗀𝘁𝘁 and Mel Racine, as the voice training specialist, which I think is a horrible name, but that is the name that was created 30 years ago, and it's just sort of the name that stuck. But I think that name says nothing. It describes what they actually bring to our setting. So that's not a great title either. So
I think
don't,
we're back to one of our original dilemmas. What does the title singing voice specialist mean? Does it indicate that there's an SLP degree behind it? Or does it mean that it's someone with specific training in different areas, a specific training regimen, but not an SLP? So I'm just throwing it out there as a thought as we try to.
or both. Does a speech pathologist who wants to work with this population also needs to acquire a significant amount of training that we did not get in graduate school? Just like you and Kari have acquired a significant amount of training that you did not get in graduate school, which enables you to comfortably refer to yourselves as singing voice specialists. Similarly, Leda and I mean, I worked clinically for easily 10 years, exclusively with voice and singing, before I really felt comfortable putting singing voice specialist on my email signature, on my CV, on my business card, because I also was spending a significant amount of time honing skills and doing continuing education that did not happen when I was in graduate school or college for any of my degrees. So I think both have to do a lot of training to have that distinction after whatever their other distinction is, whether it's a DMA or a voice teacher or a speech pathologist. So we still haven't answered the question, have we?
No, but you know what? I think we're getting closer. If we are going to at least delineate between the SLP SVS and voice teacher SVS, I love this. If we can first continue to get clarity on what is it that enables somebody to call themselves an SVS, a singing voice specialist. And then I love this idea, Marci, of putting clinical in front of it, because that is such a lovely, clean delineation between who you and Leda are and who Peggy and I are. Although, in fairness, now Peggy did work in clinic.
Right.
So
right.
I don't know if that muddies the
Yeah,
water.
and it may be that the clinical, Marci, maybe this is what you were thinking when you thought of that term, that the clinical implies a clinical degree or a clinical
Licensure.
or clinical training path.
Right.
Yeah. Yes.
Just like the use of the word therapy implies some type of licensure. I don't think the term clinical, I mean, this is what we have to decide. Does it imply some type of licensure or just where you are when you practice?
Right.
What it is that you do. But what I was interested in also is what Leda was saying earlier, that Leda, you said when you have a speech language pathologist that comes into your practice at Duke, before they are not allowed but vetted to do singing voice work or become a singing voice specialist, there's certain things that you look at or judge or test with them to see if they are qualified to do that kind of work. Can you describe what the process looks like?
Yeah, sure. I would say that process is involved in the search and hiring, and then also in the onboarding of the new employee. And this is our practice. So I can't speak of this as a universal phenomenon. But we decided when we founded the Duke Voice Care Center that we wanted the people who work with singers, the speech pathologists who work with singers, to be kind of proven, competent singing teachers as well. So we delineate that in the job announcement when we talk about what we're seeking for this person. Usually we specify a minimum of master's level training both in speech pathology and in voice pedagogy. And then we kind of delineate the skills we expect that person to have. And then as the applications start coming in and I'm sort of reviewing people's backgrounds, the initial interviews, we'll kind of talk about both their clinical background and their background as a performer and as a teacher of singing. And then, there are usually several phases of the interview. And by the time we get to an in-person interview, I've alerted that person that part of what we'll be doing is having them do a demonstration of teaching. Now, this is a little tricky in a healthcare setting because I can't have them do that with a with a patient, even if they're licensed and certified, because they are not they are not privileged in our institution. So what I typically will do is seek a voice student from the community who will volunteer, and I have that person do a demonstration voice lesson for our team, and you can learn a lot from that, just in the same way that if you're hiring in an academic setting, you learn a lot from that. So once we find the person that we think is a good match for all kinds of different things, not just their singing, but all kinds of different things that go into making them a good person to join our team. Once they're hired, and this is true for any hire, singing voice, not singing voice, whatever, our institution requires that any speech pathologist, and that would be true for other disciplines, physical therapy, even for physicians, have to become privileged at our institution. And that means that whatever services they're going to be providing, they need to have in their background demonstration that they are familiar with or experienced in those services. And then there's a period of time where they're observed doing that with a supervisor, and there are kind of several phases of that. So for example, we just hired a person on our team who has over 20 years of experience in speech pathology, very competent, highly skilled, but he still had to go through this privileging process. So he's going to do stroboscopy. So he has to go through the whole checklist, and it's a long checklist of skills on the stroboscopy with somebody supervising him until he got to a certain level of everything being checked off. He had to go through that same list with doing voice therapy. And if he's going to be working in other areas such as swallowing evaluation or swallowing therapy, he would have to get privileged in each of those areas. So that's true for anybody. We made a decision in our practice to include a separate privileging process for singing voice therapy. So if we have folks who are going to be working with singers in voice therapy, there's a whole separate checklist and supervised and privileging process for that.
Right. So it's fair to say that there's no national codified system from practice or voice center to voice center. It's just each voice center decides to what degree and how they're going to vet and train folks, no matter what their background is, to work with the singing voice. Is that true?
Yeah, just to say the privileging process, that is fairly, it's not exactly the same from institution, but a lot of that is dictated by JCAHO, for example, so there's some consistency across one health system to the next. But yes, specifically for getting all the way down into that level of voice therapy, not necessarily identical across institutions.
So we have the same problem in the medical field that we have outside of the medical practice, and that is that there's not a nationally recognized codified system for qualification or agreed upon system for qualification for the singing voice specialist. Is that fair to say?
For speech pathologists, that is correct.
Yeah.
Yeah. And I'd say also the same for laryngology, because, not all laryngologists are what we refer to as singer savvy. So, and just because somebody goes to a medical professional, ear, nose, and throat doctor that has a scope and puts a scope in and takes a look, doesn't mean that they know how to interpret it and make a decision about this elite singer as to whether or not they should proceed with their performance or cancel it. Those are that's all the meta. That's the meta kind of intervention that is not the stuff you see on paper that makes the difference between outstanding care and just care.
And it makes it so hard for the professional voice user
Right.
to know where to go, how to choose.
They don't know the difference. The transparency isn't a problem. Yeah.
One of the most fascinating aspects that we discussed last chat, and then the four of us discussed in the pre-chat, for me, there was a big shift around the scope of practice. that I'd like to open the door to conversation. And what that was is it had been told to me repeatedly that if SLPs are doing singing in the clinic, they are not abiding by 𝗚SHA guidelines or by proper coding of insurance. And along as part of that conversation, Marci brought up that it never occurred to her to think within her scope of practice of, I'm doing speech now, and now I'm doing singing, because the voice was one instrument. And so, as I said to all of you earlier, I think the shift for me was not just thinking of speech therapy that happens within the clinic in your clinical singing voice specialty scope, but that it is voice therapy. And so within that voice therapy, you are not limited to speech. That is significant, because that is not how I was told over and over and over. So please, Leda and Marci, let's talk about that a bit, because that's important.
I'm happy to jump in. Yeah, when you and I had that conversation, Kari, last year as kind of preparation for the first NATS chat, it was so funny that we both had like a, because it never occurred to me to like totally view them as I'm doing this and now I'm doing this. And you were kind of the opposite. And we sort of had I think a magical understanding as two colleagues who already had an enormous amount of respect for one another, but now having a further lens into what your narrative was and what my narrative was. And I think it's those conversations that continue to bring us closer and closer to starting to have an understanding where these conversations and topics are no longer triggering, where we're all feeling like we have to like stand our ground and defend our, our stakes, but it is more now, it is opening the door to understanding the beauty in the collaboration of these two professions to serve what is always and will always be the most important thing, the patient standing in front of you. So not distinguishing, I mean, to me, we had a voice disorders class, right? It was didn't talk about speaking voice. It talks about the things that go wrong with the functioning of voice production. So in my template, and Leda, I'd love to know if this is similar for you, it just didn't occur to me that those would be different things and to separate them out.
Leda, do you want to talk a little bit about that? I loved what you shared with us about coding and a little bit of what my questions were about that.
Yeah, sure. And Marci and I checked in on this as well, that there is not any 𝗚SHA specification that prohibits working with singing as a part of therapy. So when we're billing, to Jess's question about what is billing, there are at least kind of two things that go into that. One is a code. We are billing a code for a diagnosis, and that's this humongous, long, complex list. It's called the ICD-10 coding list, and there is a separate number for every single possible diagnosis there could be. So there's a separate diagnosis for nodules, for polyps, for paralysis. Those are typically medical diagnoses. The one diagnosis that Marci and I bill for, because we're a speech pathologist, is dysphonia, which kind of captures something wrong with the voice. And so that is that's the diagnosis that we code for. We also code for the service. We bill for the service that we provide, which in our case is speech therapy, and it's just that one code, speech therapy, whether we're working with a voice patient or a child who's working on articulation, or a person who has aphasia, and so it's quite broad what's captured underneath that code of speech therapy. So if the patient is approved for speech therapy and their insurance covers speech therapy, then that's what we provide, and that's what we bill for. And there's not a lot that goes on to dictate what the content of that is. There is a lot that talks about the specificity of language that we use, and we have to write separate goals for each thing that we're going to work on, and we have to document what happens relative to those goals in a really specific way in terms of, it has to be measurable, it has to be appropriate, it has to be relevant to what's going on with that patient. It has to be time-based, and what amount of time do we expect them to meet this goal? And then we have to adjust these goals as time goes forward, and they move further and further toward the ultimate goal of having their voice be able to do what they want it to. But there's nothing in there about singing. There's nothing in there about singing. So I'm not sure where that idea came from, but I've been doing this for almost 20 years now, and that's just not a thing that happens. That something comes back and says, well, you can't be doing this because you're doing singing. In a moment, I know we're going to talk about language of clinical documentation. And so if your documentation isn't good, then an insurance payer is probably going to contact you and have something to say. But it's not a, if I thought that for 20 years I had been doing billing fraud, that would have, I would have addressed that a long time ago, just from an ethical perspective, and I'm sure somebody else would have addressed it for me from an ethical perspective if there was something inappropriate about that.
Peggy.
Kari, can I just speak to, just taking a step back for a second, to our folks who are listening and joining us today, that this whole discussion of billing only refers to licensed speech language pathologists. It does not refer to singing voice specialists who are not licensed speech language pathologists. So when I worked, for instance, for Dr. 𝗚𝘂𝗲𝘀, nothing I did, and I'm just for clarification, could be billed through the insurance companies. I'm sure most of your folks know that, but just to clarify, that was all out-of-pocket cost to the patient.
Which is why that's so wonderful, Peggy, to make that clarification, which is why I think that so many of our singing teachers who want to do this work are going back to get their licensure, because then they can be hired in the clinic and they can charge within the clinic, within the insurance process and the billing process. And so I think that is probably contributing a lot to the way forward in this profession, that I think is important. I will say, go ahead. No, Peggy, go ahead.
No, I was going to say, a voice center is not likely to hire a voice therapist if they can choose someone who is a speech language pathologist and also has background in singing and could conceivably do both. That's the person they're likely to hire, because it is the practice that needs to be able to bill for the sake of the patient, to keep the patient on board.
And if I can just throw another thing in there for that consideration, I agree with you, Peggy, that, I think if there is an option for that, for say a physician who's hiring an SLP in a voice center, that he can hire somebody who can address singing, who is also an SLP and can bill insurance, that person also is insurable. So yes, that person also, they can, can put on the liability insurance for the practice, which also protects the practice from being sued.
And this is information for folks, yes, who haven't worked in that setting before. All of these things have to transpire.
And someone has just said, to reiterate, coding for voice therapy includes both speaking and singing voice rehabilitation. However, speech therapy codes only involve speaking voice therapy.
I would love to see where that's delineated with 𝗓ście, because I know I've certainly looked at those requirements, as have you, Leda. And so that has not been clear to me, but those are very complex and complicated things. So I certainly would be interested to know where that comes from, that information.
So
could I ask a question?
Definitely.
But if it's 𝗓ście 𝗚𝘂𝗀𝘀's understanding of it is one thing. Is the insurance company's understanding of it another in terms of scope of practice? How does that work? I think we're not talking about 𝗚SHA's position. I think what we're talking about is the insurance company's understanding of what scope of practice is under a code.
Thank you for making that distinction, Peggy. That makes more sense. Leda, you were just speaking to this issue before we went on air about how in the 20 plus years, you've had one instance where you've had to go back to an insurance company because they said this is singing lessons.
Right, and once I addressed the specifics of the case, where it's a professional singer who's lost income from singing and functionality for her involved singing, then it was dropped. Yeah, it's just, we're, again, the idea of the holistic voice, and in the context of sort of SLP and singing voice, we're not drawing those lines between. We're talking about voice function and the whole, the function of the whole instrument and different kinds of tests. So you go to a physical therapist and they're not necessarily going to say, okay, this is an exercise. You have a knee injury, we're only going to do sitting exercises for your knee, right? So they're going to say, all right, there's this exercise that accomplishes this thing, and then there's this exercise and this and these what all these exercises address, and there's a progression of ability and function, and all of it is to get you back to the point where you are walking or running if the person is a runner. It's not it's just not separated out that way. If your voice needs to function for your activities of daily living.
And I have to add to that analogy. So right now I have a patient who's a sports announcer. So he is not singing the calls on the field, but he is using his voice in a way that's different than the four of us are using our voice right now. But I am still working with him on exercises and biomechanical, biomechanically based goals to help improve his voice production so that he can do 2 back-to-back games, or if a game goes into overtime, he can use his voice at that level that is above and beyond if he's in a coffee shop with his friend talking. But that's not singing, right? That's speaking. But it's still, it's still within my scope of competence, and I feel therapeutically to bill for that, because even though that's not just conversation, for socializing, it is how he uses his voice to do his job. And I would say the same for somebody who's a professional singer, or somebody who's a
I think we're speaking to the choir here. We're speaking as healers. We're not speaking as insurance company money people. And I even see speech therapy claims denied when it has to do with voice and vocation. I mean, I've seen that happen with some insurance companies, and I'm just like, what's happening here? But this is not, we don't have to pursue this. I think we all agree what it should be and what it is, but I'm just wondering how the insurance companies think, but I don't deal with that, so.
Yeah. So we have in the question box that leads to a couple questions for me. There are a lot of singing teachers who have completed the summer 𝗚CI program and are getting distinguished as vocologists. Where do they fit? They are not practicing as SLPs, but SVSs. And I want to just say, as a non-clinical SVS, the first thing I always ask anybody who identifies themselves as an SVS, besides of course wanting to know where they trained and what their background is and all of that, with whom are they working in collaboration? In other words, who is the voice team? And so singing teachers who pick up a student here or there that has nodules or this or that, my question is always, who is your team? Are you working in affiliation and constant collaboration with your SLP and doctor? And that, I've said this 100 times on video, I think. That to me is where the conversation has to begin. But so that's my answer to that. But I would love to know your answer to that. Where do they fit?
The 𝗚CI, so Peggy beautifully outlined in part 1 of this conversation about sort of what are the perfect and ideal background and education and experiences one would need to have to be able to distinguish themselves as an SBI, whether or not they are coming at it from a pedagogy arena or a clinical speech pathology arena. Both need to have an extensive amount of education. So SBI, I would say, is part of that, but in itself does not qualify somebody to just be able to say, I can now work with injured singers, even with a medical team, if they're a speech pathologist or if they're a pedagogy person, because it's those other things, the connections with voice care professionals, Kari, that you're talking about, and the things that you and Peggy spent years learning, cultivating, collaborating, all of those things are the things that also have to happen in addition to the classwork learning, which is critical and vital. And Summer Vocology Institute is a fantastic place to get that kind of background, but it is not credentialing you to do anything. It is giving you an enormous amount of valuable and needed information, but there's a lot more to it than that.
Could we just address that quickly? It is a valuable course study, but again, there's the acquisition of knowledge and the application of knowledge. All of us understand that learning to sing is a process, and it takes time and experience, and it's a process that happens over time. So is teaching singing.
Right.
Being a really good singing teacher is something that you develop over a lifetime. It is a process also. And so is becoming a good speech language pathologist for speaking voice. That's a process. And so is becoming a singing voice specialist. But for the singing voice specialist working with the voice, the difference between that and working just as not just, but working as a singing teacher with healthy voices is that when you're a singing voice specialist, it's implied that you are working with a disorder. And then the stakes go up. So you need to know what you're doing. As Kari said, until you're extremely experienced, and even then you need to be working under the auspices and in conjunction with a speech language pathologist who is specialized in voice, as well as a laryngologist who's specialized in voice. Because even though teaching singing and working with the injured singing voice share multiple skills and approaches, you have to know what you're dealing with and why you are doing what you're doing in order to do it safely. And that takes time, and it takes supervision. That's one of the things we outlined last time. It's all this acquisition of knowledge, it's the process of practice, and it's the process of practice under supervision and collaboration. And then you learn to do it safely. It's not rocket science, but it is detrimentally significant in that you can make someone worse rather than better. And that's all I'm going to say.
So let's go back. Thank you, Peggy. Let's go back to the conversation that those who are that have experience as a singing teacher and a singer, maybe have been teaching for a decade, go back and get their Cs. If we see that as one of the ways of the future to be an SVS, a clinical SVS, for me, as I've stated, one of my concerns is that there is this assumption that because somebody has their Cs, they're more qualified to do the work than somebody who has gone and gotten this information on their own and created their team and their own practicums and whatnot. So I just want to talk from Leda and Marci's perspective about how you're feeling about that as your field is bringing more and more people to it with that varied background.
Yeah, I'm not sure I understand your question clearly. Did you have a response, Marci? I think I need a little clarification.
I was going to say, Leda, did you?
Are you saying how do we feel about people, about speech?
Let me be more.
Yeah.
Let me be more clear, because we've talked about it off camera. It's the part that concerns me, that this hierarchy, that because somebody has their Cs,
Right.
that there is this assumption that they are more qualified to do the work, and that concerns me.
Right.
The work as a singing voice specialist,
Yeah.
you say.
Correct.
Sure, that concerns me too, in the same way that, you know, if somebody has a DMA, are they inherently prepared to prepare professional singers in an academic sense, right? It's much more about, there's achieving the required sort of landmark, and then there's the skill, right? And I think Peggy just said that beautifully, that it's really about how has that person's experience developed and emerged. And so if somebody who is speech pathology, it's you have a 4-year undergrad degree, usually 2-year degree, right? Sometimes it takes people slightly longer. So assume somebody has gone straight through their whole academic program from when they graduated from high school. They're going to come out of their speech path degree 24 or 25 years old, right? And so if that person, without any background in teaching singing or performing professionally, and that person's now going to work with singers who have voice injury, that concerns me a lot, because I don't have any information that tells me they know how to build technique in a healthy instrument when I look at that timeline. So, but there are kind of many paths to this, and so I think kind of looking at the whole person and what their whole background is. If somebody, and I've heard from a number of people recently, at least 3 people last fall who came and observed in our clinic, who had a DMA in voice, had been out performing, been out teaching in various kinds of settings, and then went back to get their SLP degree. That's I'm gonna sit up and look at that, because that's a really interesting background to me. Now, when they come out of their speech pathology degree and they've just finished their speech path degree, I'm not going to expect them to be seasoned speech pathologists either. They're still going to have to learn a lot at that stage. And so you have to kind of, I think any profession, right, the longer you're in it and the more experience you get and the more learning you have as a lifelong learner, that's all going to go into how well you do your job, right? And some people takes varying amount of times to build that skill. But I think another question that comes out of that is sort of, what are people's expectations in the training path they seek, and making sure that their expectations are aligned well with the path they seek. So where do they see themselves ending up? If somebody says, I want to work in clinic and I want to pass a scope and I want to work with singers and work right alongside the doctors, and they take a pathway that is not an SLP pathway, they're going to be really limited in being able to do that. And I actually just had someone tell me recently that she had gone on to get a DMA specifically because she thought that was going to prepare her, a particular track of that, it was going to prepare her to work in a clinic. And she, she wrote her dissertation about this, and she told me afterwards that if she had understood that that was not going to prepare her to work in a clinic, she would have done the SLP path instead. And so, and again, many different ways to do this that we have discussed at length, but I think I feel an obligation to a person who's embarking on a huge financial investment, a time investment, maybe moving to a whole other place, putting their family in, a whole other kind of world they're going to be living in while this training happens. I feel an obligation for that person to know, what should I expect to be able to do at the end of this?
Yes.
And I think you may have said this already, Leda, but for folks who don't know, and Marci and Leda are very well acquainted with this, that even after you do your 2 years of study to become an SLP, you then do a year of what do you call it, oversight of work, that is where everything you do is supposed to be overseen. I forget how many hours is required before you actually get your full licensure. So, and for us as singing teachers who come out of college and start teaching voice, I mean, we have no idea what goes into a codified license system. And secondly, it's important to say, and whenever I talk to folks about this, that even though voice-centered laryngology is a rapidly growing subspecialty, there's still only a limited number of positions open for someone who wants to specialize in voice therapy as an SLP / maybe SVS. It's still limited, and there are lots of folks trying to do this. So I think it's important to reiterate that, although I always tell people, as an SLP, you can always work. It may not be in voice, but you will find a job, which is sometimes a relief to someone who's been a singer for 15 years of their lives. Anyway, just for folks who are unfamiliar with the specifics.
And I want to jump in too, Kari, to address the sticky aspect of this topic. So Leda, I mean, you, as always, you put things so beautifully, and I agree with what you said. Kari, to go back to the concern about this narrative that there's a hierarchy. If somebody, you know, if the thought of a speech pathologist who's a newer speech pathologist, or even a speech pathologist who hasn't done a lot of singing, feeling that they are somehow higher up on a pecking order than you are, or Peggy, as people who've spent their entire career cultivating this, I find that troubling. I think that these conversations that we are having and continue to have, so I hope, slowly chip away at those kinds of narratives, that there is because we're clinical, we must know more, you know, that kind of thing. I think the more we have these conversations, and I think the organizations like NATS and 𝗗𝘶𝗶 and, you know, Voice Foundation, where these disciplines come together, the more we have these conversations from a place of putting the patient at the forefront of that is what matters, and getting our own sort of triggers out of the way, and have the understanding of these narratives that are false narratives that don't serve anything. I think we will continue to get closer and closer to really understanding that this is a win-win situation that is collaborative, and that at the end of the day, the patient benefits. So thank you for asking those questions that are sticky, and sort of talks about some of that gray area, because I think there are a lot of preconceived ideas about what we think because we're speech pathologists, or what you think because you're DMA, you know. And I think the more we can talk about those things with the patient at the forefront, the quicker we can get to true collaboration and understanding of how we all serve these patients.
And valuing what each person has to offer. And I just want to say on behalf of singing teachers, putting appropriate value on an art form that is 300+ years old in its deepest roots, and has through experience and practice proven itself to be a successful process. So I think the medical field's recognition of the value of singing teachers has dramatically changed over the last 30 years. I will give a shout out, 𝗗𝘶𝗶, of course, but to the Voice Foundation, because from the beginning, one of the central purposes of the Voice Foundation of Jim Gould was to get all of these disciplines together to talk among themselves and to learn to respect each other. I mean, how long did it take doctors to really give voice specialists, physicians, to give the speech language pathologists their full due? And now singing teachers need to get their full due as well, and that's happening. That's what we're seeing. We're in the middle of this transition, and it's fantastic.
Oh, we're still having the conversation. That's fantastic, right? I mean, we're still trying to figure this out. And I wanted to say, because Joan typed in, Leda, while you were speaking, and said, so well put, it's the skill and talent when you were talking about that. And I think, Peggy, I don't remember if it was on or off camera, where you talked about Dr. Sadaloff originally said the voice teachers' skills, their ears, that, you know, gifted ears is one of the most important things that we can have to be able to do this work.
He said basically there's not a piece of equipment yet that has been developed that is as good as the ears of an experienced and excellent voice teacher at detecting elements of dysphonia. And he's absolutely right. I mean, that's huge, not diagnosing, but just that one little tiny area.
I actually agree with that in a clinical setting too. I will rely on my ears any day over any kind of aerodynamic or acoustic equipment, any day.
Absolutely, absolutely, because that you can fool that equipment in a heartbeat.
So let's take I want to get into the gray area for a moment here around the actual work. So Leda and Marci, when you're in clinic with a singer, and I love that we're recognizing you think of it as the voice. So you're doing some speech, you're doing singing, you're doing whatever restores function to the voice. How many sessions do you get with your clients nowadays? And what does that look like?
Do you want to go? I'll have to jump in. So obviously insurances often dictate how many sessions we get. So we are often working within the limitations of that. To me, one of my biggest distinguishing factors that helps me understand when I'm now exiting rehabilitation into that gray area is what their primary complaints are when they came in. I always say, if you had to list your top 3 complaints about your voice, what would they be? Fatigue, inability to do a doubleheader game, and I can't, read to my kids when I get home from work at the end of the night, whatever it is. Those 3 things. So I look for when they're starting to tell me that they are now able to return to the function that they didn't have when they came to see me for the evaluation. Fatigue is often a big one that tells me if they're no longer having fatigue and they now can do the double header, then I start to say, great, we're gonna start wrapping up our therapy. And sometimes that happens within the limitations of the insurance company, insurance allotment, and sometimes it doesn't. But that's what I go by. What brought them into the clinic to begin with? What are those top 3 complaints? And I have them rate their function each time at a scale out of 10. If it's the most miserable it could be is a 10. When I evaluated you, you told me the fatigue was like a 7 out of 10. What does it feel like now? And you see the number hopefully go down. And when we're getting towards a 3 and a 2, I know that we are wrapping things up. That's how I tend to do it. What do you do, Leda?
Very similar. We kind of form our clinical goals based on what we see happening, and so I kind of structure the treatment plan based on that. But before I ever even discuss that with the patient, I do something really similar to Marci, and I say, kind of, what are your goals? What would you like to be able to do? And I'll document that as patient stated goals, be able to go to a doubleheader or whatever you just said, and I'll document that, and I'll keep track of that from session to session, along with my clinical goals that are a little bit more systematically structured. And so I'm watching for those improvements. Sometimes that you asked how long does it take and how many sessions, it's quite variable. I have not found too many insurance payers that are super stingy about that, but some are. So for a singing patient, I will usually put the request in at 12 sessions, which seems like a lot, but we are addressing the whole voice, and so I want to make sure to have time for that. Sometimes the insurance will only approve a portion of that, and then I have to resubmit my documentation and their progress at some point along before they will, approve additional sessions. Some have no limit on how many they provide. A lot of them combine. Really common thing is 60 visits per year, combined speech, physical therapy and occupational therapy are kind of lumped together. So the way that can look in terms of what the insurance approves is quite varied. I would say in general, I probably spend somewhere between 4 and 8 sessions on average with people, sometimes a little bit more, sometimes a little bit less, sometimes a lot more, kind of depending on what's going on. If somebody has a surgery or something or they have a surgery in the middle of their therapy, then that's going to kind of extend things. But it would that would be unusual for it to go more than around 12 sessions. And I'm looking for the same things Marci said. So I make a clear, habilitation, building function in a healthy instrument, rehabilitation, restoring a function that has been lost. So I need to know what those functions are that were lost, and then I need to know when we're starting to get to the point where those have been restored. Now, inevitably, somebody walking in there, a lot of times it's going to look a lot like a voice lesson, because I'm designing a therapeutic exercise regimen for them that we're building on each week. And so there may be a period of time in a big chunk of that session that's where we're drilling through exercises like you would in a voice lesson. I'm teaching them how to complete the exercises on their own, etc. There may be a whole session where we spend the entire 45 minutes talking about how upset they are that they are not able to sing, in a really emotional session, and what am I going to do? And I can't deal with this, and I'm not able to, I'm going to lose my career, and so that might be a whole session unto itself, and that is justifiable, and I can document that, and that's part of the goals that are there too. We might spend a whole session talking about what their voice load is. If they have kind of really heavy voice demands, we might spend the whole session strategizing about how to get that under better balance, or how to start being more regular in their practice time. So it can take many shapes, and there may be a session where I spend a lot of time on speaking voice and not much time on singing, or vice versa. So it's and then I haven't even gotten into the manual therapy piece of it. So I know Marci is also trained in myofascial release and manual therapy, and there could be whole sessions that are about that. So it can look many different ways. You can see 10 singing voice therapy sessions in a row, and they could look completely different from each other. So I don't know if I answered your question, but.
Oh, beautifully, Leda. I really, I have a visual, an insight into what that looks like.
The other
appreciate it.
I just wanted to throw out that, Leda, I'm glad you talked about the recertifications that we have to do. It might be helpful. Oh, am I frozen?
You're back now.
Sorry, I couldn't test. Sorry about that. I'm glad, Leda, that you commented on recertifications. It might be helpful for people who don't live in a clinical arena where they're billing. We have to be able to document and justify functional gains, and we have to be resubmitting that information to the referring physician, who has to sign off on it, so that the insurance companies can say, okay, they need to have more therapy. And we have to do that is it every 90 days now, or is it every 60 days?
Medicare is every 90 days. But yeah, and then that brings up another point too of, at the beginning, I have to say this, I'm recommending 12 sessions for this patient that will be completed 12 weeks after their first appointment. They're going to come once a week. So we have to be very, very specific. Or I might have a patient I'm going to see every other week, and so their 12 sessions are going to be completed over a longer period of time. So, and we have to specify that. And then if I get to that date and they're not finished, then I have to submit that and say I'm changing the end date for them. So we are constantly having to be accountable for what's happening. And I think that's another reason that I'm a little puzzled by the idea that, it's doing something wrong to work on singing, or that is somehow outside of the what should be happening in voice therapy, because we are constantly being, the demand for accountability is constant for us. There's not anything that just kind of flies under the radar and we can just like keep doing something and not meeting those requirements.
And believe me, I don't think it's wrong. But Kari,
I know, and I know that Kari doesn't either. It's just every once in a while I will hear that, and I just wonder how that impression is out there, and people might feel, because there's all kinds of reasons for therapy to get denied, all kinds of reasons, and so I wonder if maybe a therapy gets denied and people assume it's because of the singing, but it may be because their Medicare plan of care didn't get renewed, or the treatment authorization didn't get in prior to when they were scheduled for their first visit, or It may be that the insurance company thinks that this is not medical necessity and we have to have our doctor have a peer-to-peer with them to say they have nodules, it's an injury, it's medically necessary. So there are many, many reasons for therapy to be denied. And I just wonder if maybe people have an assumption of what it is
I
without.
think for me, the perception was around what I had heard about 𝗚SHA guidelines and coding from the billing, and the idea of scope of practice, speech therapy, singing, right? That there was that the training that has been undergone to become a licensed speech language pathologist is around speech. But again, what you two have illuminated so beautifully, it's around function of voice. So if we change it to voice therapy, then it feels very different, the scope of practice. So I'm not sure if that's where it came from. Peggy?
A quick question. I know we don't have a lot of time left, but for both Leda and Marci, when in the process of working with a singer and rehabilitating, or not rehabilitating, but working with therapy with a singer who has had a voice problem, when do you bring the voice teacher, the private singing teacher back in? Are they a part of it all along? Do you oftentimes just see the singer for a bit and then bring the teacher back in? I think this is something that people might be interested in, if we have time to just quickly refer to that.
Yeah, my preference would be for that singing teacher to be there right from the beginning.
Yes.
And, I mean, I love if a singing teacher comes in to the eval with their student, I love that. And I will say to that singer, say thank you to your voice teacher, because this is a big commitment of their time coming in here because they care about you. And I mean, and there are times when given medical release permission, of course, by the patient, we'll have a regular interaction with that teacher, and I want to dovetail what's happening in the therapy. So I'm not just, okay, here's your therapy exercise and here's your voice lesson. I want to know what they're doing in their lessons so that I can dovetail what we're doing in the therapy to align that to help those mesh. And I mean, I am, in most cases, I would love to have the teacher there for the whole process. Sometimes that happens. Many times the patient does not have a teacher, and
Right.
so that's kind of moot. Sometimes they have a teacher, and that teacher, for one reason or another, doesn't want to participate. So it can take many forms, but I would always much rather collaborate with the teacher, because the teacher knows the singer. That if I ask the singer, how much time are you spending in a practice room working, and they're like, oh yeah, an hour every day, and the teacher's like, or there are many other, or may understand things about their background, or what's going on with them academically, or there's just so much. It's so much better and collaborative when we work together.
I agree with that 100%, Leda. And I'm always surprised if a teacher doesn't want to participate in it, because I would much prefer the teacher be involved. And FaceTime and Zoom, I've had teachers Zoom in to their lessons where the teacher's in another state, but the patient's with me. I've had them FaceTime during the evaluation. I mean, that's one of the nice things about the technology, and COVID has sort of really opened up the telecommunication, so the teachers can be present even if they can't physically go with their patient, which is very helpful, I find.
Peggy, I'd love to know from you. We've heard from Leda and Marci what their day looks like in clinic. And with your 20 years in clinic, when you had, I'm sure in that 20 years, it kind of changed the SLP, the clinical SVS and the voice teacher SVS. Can you give us a picture of that from you, and how that might emulate what you heard Leda describe, or be different than?
I think it's very similar. In Dr. 𝗚𝘂𝗲𝘀𝗁's office, every patient who came in with a voice complaint did speech and singing, whether they were a singer or not. I say this all the time. In the beginning of my time there, and actually it was 29 years, I just have to make that point.
Thank you.
Anyway, no, it's not that. So in the beginning, I thought, gosh, is it really legitimate or ethical to ask these non-singers to do singing? And I swear to you that without fail, 9 times out of 10, the person who was a non-singer who had to do speech and singing came out of the process saying, well, I never thought I could do that, but that has been really helpful to me. But what was important in that setting and his team, voice team setting, is that we collaborated totally all the time. If somebody came in with basically a speaking voice complaint and Dr. 𝗓𝗏, and they were doing both speech and singing, I would defer to the speech language pathologist, whatever they were working on. I would ask them what they wanted me to do, and I would complement their work. So we sort of double team the voice, if you will. And I don't know, I thought it was a pretty effective model, quite honestly. And vice versa, when somebody came in with mainly a singing voice complaint, we both would continuously collaborate about what we were working on, the exercises, because sometimes the exercises overlap. So it was a very collaborative environment. In terms of how long we saw patients, it depended on the situation, it depended on the diagnosis, on the circumstances, and it could vary widely. I would say it was never less than 6 to 8 sessions, and sometimes more than that, depending on the nature of the problem. And I too always wanted to include the voice teacher in the process, the singing teacher, if there was one. If for any reason the singing teacher wanted to step out of the process in the beginning, I would certainly try to communicate with them as the singer returned to their teacher, if that's what they were going to do, and explain what we had worked on and why. I was always very careful to try to present to the singer. Sometimes you present to a singer new ideas, especially about the release of tension or something else that might seem to them to go against what they've been doing in their singing lessons, and that's where you have to be a super diplomat. But I think always trying to communicate with the singing teacher is very, very important. Did I answer your question?
You did beautifully, as always. Yes. Oh goodness, ladies, we could talk all day. You know,
next year.
I know we may have to and go even deeper into the gray area to see what we can uncover. But I love that I've learned through these 2 NATS chats from all of you about, you know, the evolving nature of this field, and keep checking my own biases and my own narrative. The one thing that hasn't changed is that the voice team is critical, and that we as singing voice specialists have to work very hard to find our journey into the right training, to the very multifaceted depth of training. And then I think, especially for singing teachers, to find somebody to do a practicum with and have something that emulates the fellowship that speech language pathologists are required in order to get licensed. So I think that we have to continue to be very cognizant of that as voice teachers. So thank you so much. I'm always so honored to spend time with you.
Thank you, Kari.
Great, thanks for inviting us, Kari. And just to pick up on what you just said a beautiful thing a moment ago about the team, and no single person on the voice care team has everything that is needed to put that singer back where they need to be. There is no person that you can pull off of that team and say, oh, this person can fix everything, or this person can take care of it. It really has got to be collaborative.
Wonderful. And I think we've demonstrated that, haven't we?
Can I
the
say one more thing?
collaboration, right?
The collaboration
Please.
and care of the emotional state of the patient also is very, very important. We haven't talked about that at all. We tend to talk about the specifics of therapy and what we're doing, but a big piece of this is the psychological, emotional care of that individual. And a lot of it is left up to the therapist or the singing voice specialist. It falls in our lap. The physician is very, very busy, and we have all kinds of responsibilities, including that care, including triaging between the patient and the physician, including interpreting and being a translator. There's so many hats that you wear as a therapist in a practice and working with a patient.
And those are not the things that you learn at some of these outstanding continuing ed things like SBI or like, you know, just an outstanding conference. It's that meta component that is really what makes it a craft and not something that's technical. And I totally agree with you. It's the unspoken that doesn't show up on paper.
And I think Peggy has just beautifully outlined our NATS Chat 3 on the SVS collaborations and conversations, because that emotional component is such a part of what we do. And then here we are again, stuck in the scope of practice. How far do we go down that path before we refer to somebody who's trained in the psychology?
Kari, would you ever consider a meeting of us where you present us with a patient scenario, a singing patient scenario, and talk to each of us about how we might approach that scenario from a therapeutic or technical direction?
I think there's part 4 or 3. Brilliant. Yes, NATS chats do tend to be more, conversational, but I think, yes, let's talk about that as a potential future. I think that people would really respond to that. So, and I look forward to our collaborating on an article, ladies.
Yes.
In our free time.
That's right.
Thank you, Kari.
Thank you.
Thank you, everybody.
Thanks so much, Kari.
Thanks for the, please join me for the last NATS chat of this season, May 21st, learning about Latin American and Spanish music. So I hope to see everybody for that one. And there may be a couple this summer. I'm in conversation with 𝗚𝘂𝗲𝘀𝘁𝘀 about doing a special edition NATS chat about updating from Zoom. Where have we 3 years into COVID moved into the technology aspect? So stay tuned for that. Thank you, everyone, so much for joining us, and be well.
Thanks, everybody.
Thanks.
Bye-bye.